Mohan sir, can we start now?
Starting.
Yes, sir. So, good evening, everyone. So, today we are having the second series of our ODC, an OSCE series for postgraduates by IAP Kozhikode PG Club. And today we have a genetics OSCE session by our own dear IAP Kozhikode President, Dr. Mohan sir. Sir is also the professor and HOD of Department of Pediatrics, Government Medical College, Duki. And sir is also looking after the genetics clinic of Calicut Medical College. And he's been the in charge, and he's a known speaker in international platforms. So over to you, sir, for genetics OSCE.
Thank you, Ajay. Hope I am audible.
Yes, sir.
Am I? Okay. Let me share my screen. Okay. Is it visible?
Yes, sir.
Okay. So today this is the second session. Last week we had a session on immunization. Usually in DNB OSCE you get 3 or 4 situations where it is based on genetics. So naturally we will not be able to cover the entire topic. We will be discussing some aspects. And I would like to include some questions regarding pedigree analysis and a few questions regarding interpretation of genetic test reports and counseling scenarios and some of the clinical scenarios. Okay. So in this session, I won't be able to ask questions to each person. So you can try to attempt the answers yourself. And once the answers are discussed, you can verify whether it is correct. Okay. So there are so many symbols used in drawing a pedigree. So here I have shown 5 of them, and you should tell what it means. So these symbols are given as a chart in Nelson. I think all of you might have gone through that. The first thing, so first is pregnancy, and the diamond shape indicates that the sex is not known, and the shaded area, that means it is affected by a genetic disorder. And the second one is the proband. Proband means an affected person coming to medical attention independent of other family members. So here it is shaded, so it is a female, affected female coming for genetic opinion. Whereas a consultant means any individual seeking genetic counseling or genetic testing. It need not be an affected person. And the third one is monozygotic twin. The line connecting these two lines means that it is monozygotic. If there is no line, that just means it is a twins. And the fourth one, there are 2 parallel lines. That means shows there is infertility. The couple is infertile. If there is only one line, that just means that they don't have any children. And the fifth one, here you can see the bracket indicates it is an adopted child, and the vertical lines coming to that person. One is a continuous line. That means there is a biologic relationship. That is this child's actual mother is the first lady, and she is the sister of the other lady, and this dotted line shows it is an adoption. And if this first lady has donated an ovum, and this child is conceived by the other lady, there is a biological relationship. In that case, the line will be continuous. Again, some more symbols. You can try to answer quickly. Here, the first one, there is a star, which means you have evaluated that patient or person by yourself, or you have gone through all the medical records. So that means it's a documented evaluation. And the second one, the dot means it's a carrier and not likely to manifest the disease. And the third one is, actually, it is an affected person, genetically abnormal person, but at present it is asymptomatic. It could be a pre-symptomatic carrier, can exhibit symptoms later. And the fourth one, E+, E is evaluation. So some evaluation is done, and it is abnormal. You have identified some abnormality, that is E+. It could be an echocardiogram, it could be some genetic investigation, and that details also you can write there. And the last one, as I had mentioned in the last question here, the two ladies are from different families, and the last one, the third one, is a donor. She has donated the ovum. So there is a continuous line to the fetus. So that there is a biological relationship. And the second lady has conceived. So there also is a biological relationship, because the teratogenic effects or some infections to the mother all can affect the baby. So both the females are having a biological relationship. So both lines are continuous lines. So you can go through this pedigree and try to answer the questions. What is the inheritance pattern? List 4 conditions inherited in this pattern. Who are all the obligate carriers of the disease? Then in the generation 3, the 6th individual is coming for a premarital counseling at the age of 18 years. How will you explain the risk of having the disease to her offspring? And in the generation 4, the first person, what is the risk of the offspring of this person for having the disease, and why? Here, all generations are affected. So you tend to make a diagnosis of autosomal dominant, but at the same time, you can see that only males are affected. And another thing is, none of these affected individuals have an affected parent. And again, the affected males are not transmitting the disease to his son. So all these features are suggestive of an X-linked recessive inheritance. Absence of male-to-male transmission is very, very important when you make the diagnosis of an X-linked inheritance, because a male individual do not receive the X chromosome from his father. So this is an X-linked recessive inheritance. You can so many conditions are there, so you can write any four of them. Then the obligate carriers means even without testing the carrier status, you can say this particular female is a carrier. So if a female have two affected children, obviously she will be an obligate carrier. Similarly, if a female is having an affected son and an affected brother or uncle, again she will be an obligate carrier. So here in the last one, that is the generation 4 one is affected, and naturally and her uncle, this generation 3 second person, she is having an affected son and an affected uncle, so she is an obligate carrier. So since and here her mother should be an obligate carrier because she is having an affected son and also her daughter is an obligate carrier. So naturally she should also be an obligate carrier. So since this generation 1 second female, she is having one affected child, affected son, and a carrier daughter. So obviously this first generation second, she is also an obligate carrier. Similarly here, since in the third generation the fifth person is an affected person, and so the second generation fifth lady is an obligate carrier because she is having an affected son and an affected brother. So you can try to identify who are the obligate carriers. And regarding the third question, the generation 3, 6. So she's not an obligate carrier. We don't know whether she's a carrier or not. So without knowing that, we cannot definitely say what is the recurrence risk to her children. So since her mother is a carrier, there is 50% chance that this lady, that is a generation 3, 6, is a carrier. And if she is a carrier, there is 50% chance that her sons are affected, and 50% chance that her daughters are carriers. So first thing is to know the carrier status of that lady, then only you can counsel. If without knowing that, you can arbitrarily say that there is a 25% chance of her sons being affected and daughters being carriers. But the better way is to do the carrier analysis of this lady and tell the risk. Because if she is not a carrier, absolutely there is no risk. What is the risk to have? Risk to the offspring of fourth generation first individual for having the disease. So the male is having an abnormal X chromosome, and that is given to his daughters, and all the daughters will become carriers. And his Y chromosome is given to the sons, and none of his sons are affected. So there is no risk of his offspring to be affected. So in this pedigree, the generation 3, 1, that is the male affected person, is seeking your opinion regarding the risk for the disease to his offspring. How will you counsel? First, you should try to identify what sort of inheritance pattern is this. So here, all generations are affected. So the first tendency is to think of an autosomal dominant inheritance, but you can see that this first generation, first individual, that lady is having 3 children and all the children are affected. And among the 2 affected males, his 2 children are not affected. So the male is not transmitting the disease. And the female is transmitting the disease to all children, which is obvious in the case of the generation 1 first person and also the generation 2 second person. She has transmitted the disease to both the children. So in this situation, the most probably this is a mitochondrial inheritance. You know that only the ovum is having cytosol and cytoplasm and mitochondria. So the mother can only give mitochondrial genome to the children. So here, and another thing is all the children will get this mitochondria and all of them will be affected. So that is shown in the pedigree. So in that case, the counseling will be, first of all, you should try to identify what exactly is the condition. That also is important. And based on this pedigree, since the male cannot transmit the disease to the children, there is no risk. But it is not a right thing to provide the risk without knowing what exactly is the underlying condition. Based just on pedigree, it is not a correct thing. Identify the pattern of inheritance, give reasons, and give examples of diseases inherited in this manner. So here, there are affected individuals in all generations. And what you can see is the affected female has transmitted the disease to both male and female children, but 50%. So obviously it is not a mitochondrial inheritance. And again, you can see that the male has transmitted the disease and the male has transmitted the disease to all the 3 daughters and none of the sons are affected. So females transmit the disease to both male and female, and the male has transmitted the disease to all the daughters. So here, naturally, it is through the X chromosome, because the father gives X chromosome to all the daughters and none of the sons. So this is an X-linked condition, and since it is shaded, both male and female are shaded, so the females are also manifesting. So it should be an X-linked dominant inheritance. So you can think of conditions which are X-linked dominant. And the reason for this pedigree being X-linked dominant is because the male is transmitting the disease to, affected male is transmitting the disease to all the daughters, and affected female is transmitting the disease to 50% of the children, both male and female, because mother is transmitting, giving the X chromosome to both son and daughter. And both the male and female are shaded, so it should be a dominant pedigree. And it is very characteristic that there is no male-to-male transmission. If there is a male-to-male transmission, you cannot make a diagnosis of X-linked inheritance. And in certain cases, of X-linked dominant inheritance, since the male receive the abnormal X chromosome and there is no normal X chromosome in that male, the disease tend to be severe than the female who have an affected X chromosome and a normal X chromosome. So naturally, the male will have severe manifestations and the female will have milder manifestations. And sometimes it can be to the extreme that the male have very severe manifestations, so that the male are not born alive. It is lethal to the male, and only females will be born with the disease. So that is another extreme situation in X-linked dominant inheritance. So identify the inheritance pattern. What are the features? We have already discussed. The affected female is transmitting the disease to all the children, irrespective of the sex, whereas the affected male is not transmitting the disease to any of the children. So naturally, it should be mitochondrial inheritance or maternal inheritance. It is otherwise called as maternal inheritance. And another feature of this mitochondrial inheritance is heteroplasmy, where the amount of mitochondria received by each offspring can be different, so that the severity of the disease can vary widely. So even though all the children are affected, some of them may be so mildly affected that they may not be identified as affected, and some of them can be very severely affected. So that is called a heteroplasmy. And the conditions of mitochondrial inheritance are myoclonic epilepsy, racquet fibers, mitochondrial myopathy, encephalopathy, lactic acidosis, complex episodes, MELAS, chronic progressive external ophthalmoplegia, Leber hereditary optic neuropathy. And so that is another thing is there is some other conditions in which mitochondria is affected, like mitochondrial energy depletion and all. And some of these conditions are not mitochondrial inheritance. It can be inherited in an autosomal recessive condition. So mitochondrial inheritance means the abnormal gene is in the mitochondrial genome, whereas all the diseases where mitochondrial function is affected need not be mitochondrial inheritance. It can be autosomal inheritance also. So sometimes you diagnose the condition as autosomal dominant, but both parents can be clinically normal. So usually in autosomal dominant disorder, for an affected individual, there will be an affected parent. So if there is no affected parent, how will you explain that? The commonest situation is the de novo mutation. The mutation is occurring to that individual for the first time. The previous generation is not affected. Another thing is there can be something called incomplete penetrance. That means the abnormal gene will be there, but there won't be any clinical manifestation, which is called incomplete penetrance or skipping the generations. So this individual who seem to be unaffected can transmit the disease to children. And there is another situation called variable expressivity. The severity of the disease can be variable. It can be sometimes so mild that that individual may not be identified as affected. So that will automatically become similar to incomplete penetrance. And another thing is germline mosaicism. That means the parent will be having this abnormal gene only in his germ cells, that is sperm or ovum, so that the somatic cells are unaffected, so the disease will not be manifested. But that individual can transmit the disease to the next generation. So that you sometimes observe in conditions like osteogenesis imperfecta and all. So you should be very careful in telling the recurrence risk. So you may think that the condition has started from that individual and the previous generation is unaffected, and you may think that there is no recurrence risk, but there can be if it is germline mosaicism. What sort of genetic conditions are more common in children born to consanguineous couples? How much times increased risk of genetic conditions are there in third-degree consanguineous marriage compared to non-consanguineous marriage? And what is pseudo-dominant inheritance? So we have seen you highlight whether there is consanguinity or not, even when there is the child is having Down syndrome, and obviously we know that consanguinity has no role to play in conditions like Down syndrome or other some autosomal dominant conditions and all. Only autosomal recessive conditions are related to consanguinity. And it is shown that third-degree consanguineous marriage is having 2 times increased risk, that is just double the risk for a genetic condition than non-consanguineous couples. So if it is non-consanguineous, the risk is around 3 to 4%, and consanguineous, the risk is 6 to 8%. And pseudo-dominant inheritance is also related to autosomal recessive condition. So when you draw the pedigree, you will see affected individual in all the generations, and you may think that it is a dominant inheritance, because dominant inheritance, it is something called as vertical. You get affected individual in all the generations, whereas recessive, it is horizontal. You usually see affected individual in one generation only. But when a particular group or is a highly inbred society, so there are a lot of consanguineous marriages between a small number of individuals. The well-known example is the Ashkenazi Jews, and their carrier frequency of various autosomal recessive conditions are very high. For Gaucher disease, every 1 out of 14 are carriers. For cystic fibrosis and Tay-Sachs, every 1 out of 25 are carriers there. So there is every chance that even though there is no definite consanguinity, 2 carriers will get married. So such a pedigree will be called as pseudo-dominant. Another example what we see in Kerala is sickle cell anemia among tribes in Wayanad district, where they are very small number and they are highly inbred community. I will explain an X-linked condition in a female. Usually X-linked conditions manifest in males. So we have already discussed one situation, that is X-linked dominant inheritance. Another rare situation is homozygosity for that particular condition. For example, if a hemophilic father and a carrier female are marrying, sometimes the daughter can get both abnormal X chromosomes. So homozygosity is another situation. Then in case of Turner syndrome, that individual is having only 1 X chromosome, and if that X chromosome is abnormal, carries a mutation for hemophilia or hemophilia and all, Duchenne and all, they can manifest. And another situation is 46XY female. Even though it is a female, she's having only 1 X chromosome, and that can be abnormal. And another situation is skewed X inactivation. Even though there are 2 X chromosomes, 1 X chromosome is inactivated. And it is actually random. If a particular individual, female, is carrier for, say, hemophilia, naturally, if there is random inactivation, 50% of the normal X chromosome and 50% of the abnormal X chromosome are inactivated. So the disease will not manifest. But if most of the, by chance, if most of the normal X is inactivated, she can manifest the disease. It is otherwise called Lyon's hypothesis. And another situation was the mother is having mild manifestations and the offspring is having severe manifestation. So the well-known example is conditions with the triplet repeat expansion, where with each generation the severity increases. That phenomenon is otherwise called as anticipation. The well-known example is congenital myotonic dystrophy, where usually we diagnose the problem in a newborn who is born floppy and ventilator dependent. And when you carefully examine the mother, you can see some manifestations of the disease, which was not diagnosed till that time. And other situation can be autosomal dominant with variable expressivity, X-linked recessive conditions where the carriers can have mild manifestations. In case of Duchenne muscular dystrophy, the carrier female can have some hypertrophy, some weakness, and all. Now we will go to some of the reports. Here, the parents of a child, Nimisha. Nimisha is the child, a 3-year-old girl with Down syndrome. Came to the genetic clinic. Father is 40 years and mother 30 years. Mother is now pregnant, 8 weeks. Karyotyping report of Nimisha is shown. Identify the abnormality and how will you counsel regarding the risk of Down syndrome to the fetus. So you can go through the chromosome. So here already it is mentioned that Nimisha is having Down syndrome. So first thing you should look for is the 21st chromosome. You are seeing only 2 21st chromosomes, and the total chromosome number is only 46. So obviously it is not a non-disjunction. Then the possibility is it could be a translocation. So you can look whether it is not similar. So you can see that in the 14th pair, one is very small and the other is large. So that is the translocated chromosome. So it should be, so since it already is mentioned that she is having Down syndrome, this karyotype should indicate a 14-21 translocation. So in an affected child with the 14-20 translocation, the total number of chromosome will be only 46, but the one chromosome will be larger and equivalent to 2 chromosomes. So the third 21st chromosome is attached to the one of the 14th chromosome. So this is a 14-21 translocation. Now you can think about the risk. So here, this child is having translocation. That doesn't mean that you can straight away tell what is the recurrence risk. Always you should. So in case of Down syndrome, the indication for doing the karyotyping of the parents is when you document a translocation. In almost 95% of the situations, it will be non-distinction. That is, there will be 47 chromosomes, and in that situation, the parents' karyotyping is not indicated. So here, you should do the karyotyping of the parents. And if both parents are normal, then the recurrence risk is just age-related risk. So she is 30 years. So you can go through what is the risk for a 30-year. It will be somewhere less than 1%. Whereas if the father is carrying this abnormal chromosome, so father is unaffected, so that means he will be having only 45 chromosomes, and one among that 45 will be this translocated chromosome. So if the father is having abnormal chromosome, the recurrence risk is 1 to 3%. And if the mother is having this abnormal chromosome, that is, mother is the translocation carrier, the recurrence risk is somewhere around 10 to 15%. So that is how you should tell the recurrence risk. Just by seeing that the girl is having this translocation, you should not jump to say the recurrence risk. I have seen students mentioning that just on seeing 21 translocation to a child, the parents are counseled that you can have 100% risk of having the next child to have Down syndrome. But the parents may already have an unaffected child. So only after doing the karyotyping of the parents, you can say the recurrences in translocation situations. So here, this is the chromosome analysis of a 5-year-old girl with a short stature. What is the abnormality? Name 4 endocrine problems you expect while following up this girl. So whenever you get a question like this, 5-year-old girl with a short stature and a karyotyping, naturally you will be thinking about Turner syndrome. So you will be concentrating on the X chromosome. Here you are seeing 2 X chromosomes, and all other chromosomes are also normal. So keeping Turner syndrome in mind, you focus on the X chromosomes. You can see that one X chromosome is small and the other one is large. And the centromere of the large X chromosome is in the center. So here, this large X chromosome actually carries 2 Q arms. And that X chromosome do not have the P arm. So this type of chromosome is called isochromosome. So this is a mirror image of the Q arm. So if you look from the centromere, it is having a Q arm above and below. So this is an isochromosome. And actually, if the individual is having monosomy for XP, that individual will manifest with the Turner syndrome. So absence of the P arm of one X chromosome is the deciding factor in Turner syndrome. So this individual is having only 1 XP and 3 XQ. So actually this is Turner syndrome with the isochromosome X. And you can mention the endocrine problems you see in Turner syndrome. This is another picture of isochromosome X. Similarly, sometimes you see a ring chromosome X. In ring chromosome also, usually the P arm will be abnormal, and that situation also, if the patient is clinically short stature and fitting in with the Turner syndrome, and you see 2 X chromosomes, among that one is a ring chromosome, still you can make the diagnosis of Turner syndrome. So apart from monosomy X, you can have isochromosome X or ring chromosome X in this situation. And again, apart from monosomy for XP, what other chromosomal abnormality you specifically look for in Turner syndrome? So when you are counseling regarding various complications, one important aspect is whether that individual is having any Y material. Sometimes it may be a mosaic Turner syndrome with X0 and XY. So if there is a Y material, there is an increased chance of malignancy like gonadoblastoma. Sometimes you may get karyotyping reports, you will have to expand it. The first one indicates a deletion in the 7th chromosome, and the part distal to Q11.23 is deleted. In the Q arm, there is a deletion. The second one, there it is shown that the plus MAR is marker chromosome. This is an extra material, but it is normal. And the third one is you can see two types of patterns. One is 45X among 30 cells analyzed, 14, almost 50% have 45X and another 50% have 46XX. So it is a mosaicism in 1:1 ratio. And the fourth one is the ring chromosome X. One X is normal X and other is ring chromosome X. And the portion from P21, a small part of P arm and a small part of Q arm are lost. P21 and Q27. Distal to these 2 points are lost when the ends are fused together. So that is ring chromosome. And the last one, T means translocation, 2 and 8, between second and 8th chromosome. And Q33 is in the second chromosome and Q24.1 in the 8th chromosome. So distal to Q33 from second chromosome, that part has gone to 8th chromosome, and the part distal to 24.1 from the 8th chromosome has come to second chromosome. So this is a chromosome 2-8 translocation. So this is an investigation report. What is this investigation and how will you interpret? So there are some details given here. The child is being evaluated for Williams syndrome. So you all know that for Williams syndrome is a microdeletion syndrome, and the investigation we usually ask for is the FISH test, fluorescent in situ hybridization. And the blue things are chromosomes, and you know Williams syndrome, the abnormality is in the 7th chromosome. So the green signal, you can see the 2 green dots there. It is the a control probe. So both the 7th chromosome, you can see the positivity for the control probe. That part is not deleted. Whereas the red is the specific probe for the Williams syndrome, and that is attached only to 1 7th chromosome, and the other it is absent. That means in 1 7th chromosome, that particular segment is deleted. So this is suggestive of if this child is evaluated for Williams syndrome, here this shows that the child is having deletion of that particular region. Here you can see another case where you can see 2 red and 2 green signals. That means this child is negative. There is no deletion for Williams syndrome. Okay, so you have one child who is clinically diagnosed as Duchenne muscular dystrophy, and usually we initially do an investigation called MLPA. And as you know, Duchenne muscular dystrophy, the problem is in the dystrophin gene, and it is the largest gene among all the somewhere around 20,000 genes in our genome. And it is having 79 exons, and there can be deletions or duplications in any of these, a single exon or multiple contiguous exons. So that can be identified by the investigation called MLPA, multiplex ligation dependent probe amplification. So in this particular case, they have reported that this child does not show deletion or duplication in any of the 79 exons in the DMD gene. So with this, you cannot rule out Duchenne muscular dystrophy, because This deletion or duplication you can get only up to say 85 to 90% of cases. Next, rest of the cases, 10 to 15% can be point mutations, which is given in that particular report itself. So you have to look for the point mutations to confirm or rule out the possibility of Duchenne muscular dystrophy. So looking for point mutation, either you can do the sequencing of DMD gene, which is difficult because of the large size of the gene. So usually we go for clinical exome or specific panels for muscular dystrophies and all. So it can be still Duchenne muscular dystrophy, or it can be some other muscular dystrophies like limb-girdle muscular dystrophy. And you know what are the various differential diagnoses when in a child with a progressive proximal muscle weakness. This is another situation, clinically suspected as spinal muscular atrophy. How will you proceed? Here, again, they have done MLPA, and that particular child did not show, the child shows the presence of exon 7 and 8 of SMN1 gene. So you know, deletion of SMN1 gene, exon 7 or 8 of SMN1 gene can cause SM. So here there is no deletion. That means you cannot confirm spinal muscular atrophy in this child. So what they have written is even this deletion is seen in up to 97 to 99% of cases. A small percentage of cases of SMA can still be point mutation. So what you can do in that situation is, if the MLPA is found as negative, you have to reassess the child clinically. Sometimes your clinical diagnosis can be different. And if SMA is the possibility, you can either go for the gene sequencing, or you can go for the clinical exome or test including specific panels of genes. And again, in case of spinal muscular atrophy, another important aspect of the genetic evaluation is how many copies of SMN2 genes are there. So sometimes you may have 0, or sometimes you can have up to 5. So the copy number is important when you assess the genotype, phenotype correlation. So if the SMN2 copy number is less, if it is 0 or 1, it can be clinically more severe. If it is 4 or 5, it can be mild, something like SMA3. And that knowledge is important when the child is started on certain medicines also. And another thing is now these clinical exomes are very frequently done, and you may get certain genetic abnormalities, and they may write it as something will be written as pathogenic. So there is no doubt child is having an abnormal gene which can cause the disease. Sometimes you may get a report that there is an abnormality which is likely pathogenic. So here you should be careful. You can compare whether the clinical problem and the investigations, other investigations in the child is correlating with that particular clinical condition. And sometimes you may get a report as variant of unknown significance. So here the correlation is still less. So if clinically everything is fitting in with that particular diagnosis, you can give importance to variant of unknown significance. Otherwise, you should neglect that finding. So these are some other points when you interpret clinical exome reports. I hope you might have gone through various clinical exome reports by now. So this is a report, part of the report, where Master V is evaluated for mental retardation. the test report is attached. When will you say? So here what you can observe, they have looked for this CGG repeats. CGG repeat is looked for when you suspect Fragile X syndrome. In the Fragile X mental retardation gene, FMR1 gene, you look for the how many CGG repeats are there. Here it is more than 200, and they have already written that the number of CGG repeats fall within the full mutation range, more than 200. So the child is having Fragile X syndrome. So you can have sometimes a normal number of repeats. Anything less than 40, 42 CGG repeats are called as normal. 42 to 58 something is called as a gray zone. And in some textbooks, less than 50 is taken as normal, and more than 50, less than 200 is considered as pre-mutation. So between 50 or 58 and 200 is considered as pre-mutation, and more than 200 is considered as mutation. So what is anticipation? That we have already mentioned. In successive generations, either the disease manifestation will start earlier, or it will be severe. And this nature is usually seen in conditions with the triplet repeat expansions. Give a few more examples for triplet repeat expansion disorders. We have already discussed about congenital myotonic dystrophy, some of the spinocerebellar ataxias, and give an example for contraction of repeats causing manifestation of a disease. So this is expansion. Triplet repeats are expanded. So in successive generations, if the number of repeats are coming down, that will cause manifestation of disease. So one example like that is facioscapulohumeral muscular dystrophy, where contraction of D4Z4 repeat array causes hypomethylation, and the disease manifests. In triplet repeat expansion disorders, the hypermethylation is the cause for the disease. So this is a child with a short stature. Identify the X-ray features and give the diagnosis. So obviously this X-ray is not normal. There are few more X-rays. This is so you can go through what abnormality you are seeing. Okay, so here the abnormalities are: one is bullet-shaped phalanges, metafacial changes in the metacarpals. Then in the vertebrae lateral view, posterior scalloping, there is a concavity in the posterior part of the vertebrae, and there is an exaggerated lordosis, exaggerated lumbar lordosis. Again, the iliac wings are squared, and the acetabulum is shallow and horizontal. There is flaring of the metaphases, and there is a loosened area in the upper end of femur, which can be compared to an ice cream scoop. And you can assess the interpedicular distance from L1 to L5. So usually from L1 to L5, interpedicular distance increases. Here from L1 to L5, that distance is decreasing. So all these features are suggestive of achondroplasia. This is another X-ray child with a short stature. Identify the skeletal findings and diagnosis. Here also, it is very obvious that these X-rays are abnormal. You can try to identify the abnormality. Okay, here in the first X-ray, you can see the oar-shaped or spatula-shaped ribs. That is, posteriorly, the ribs are very narrow, very okay. And in the lateral view, you can see a gibbous, and also you can see a severe platyspondyly. The vertebral bodies are very flat, and it is something like a tongue-shaped vertebrae. And in the X-ray hand, you can see posteriorly, sorry, the club-shaped metacarpals. The club, when you say the club, it is something like the club which is shown in the picture. The place where you hold it is narrow. So club-shaped metacarpals. And the articular surface of radius and ulna face each other to have something like a V shape. So all these features are suggestive of these features collectively are called dysostosis multiplex and usually seen in mucopolysaccharidosis. And here the child presented with a short stature, and this much of platyspondyly is very characteristic of Morquio disease. And you can see the flaring of the iliac wings, and the iliac bone is actually hypoplastic. The iliac wings are flared and the iliac bone is hypoplastic and shallow acetabular. And the femoral head also is hypoplastic. Okay. And another important thing in conditions like Morquio is they have very high risk of atlantoaxial dislocation. So they have to be evaluated for atlantoaxial dislocation, and prophylactically surgical intervention has to be done to prevent that complication. Not only in another important condition where you can have this complication is Down syndrome, but it is not that much increased risk in Down syndrome, but in Morquio the risk is really high. And in achondroplasia also there is a risk of atlantoaxial dislocation. And another skeletal dysplasia called what is that? Spondyloepiphyseal dysplasia. There also the risk of atlantoaxial dislocation is really high. So identify the clinical finding and diagnosis here. So you can go through the pictures. I will show a few more pictures. Okay. So here you can see the coarse face and anteverted nose, gum hypertrophy, and there is a lot of Mongolian spots. This much Mongolian spots usually are not normal. And the Mongolian spots are extending to the anterior part of trunk, that again is abnormal. You can see inguinal hernia also if you carefully look at the lower end. And in the X-ray you can see anterior beaking of the vertebrae, not in all vertebrae. L1 anterior beaking, and osteopenia, proximal tapering of the metacarpals, as we discussed in the previous case, flexion deformity of fingers, and the lymphocytes, evacuation of the lymphocytes. All these features are suggestive of GM1 gangliosidosis. A 5-month-old baby girl born at I think we will stop with this case. It's already 9 o'clock. A 5-month-old baby girl born at term with a birth weight of 3 kg was admitted with recurrent pneumonia and oral thrush. She had undergone cardiac surgery in the neonatal period. Examination revealed severe failure to thrive, oral thrush, intertrigo, and mild hepatomegaly. So this is an investigation report which we have already seen previously, and this is the child. So what is the diagnosis? Definitely, this is a microdeletion syndrome because there is only one red signal in the picture, and the child is having dysmorphism, and the clinical description with the congenital heart disease and immunodeficiency. So the diagnosis, Dijk's syndrome. Investigation was a fish test and peripheral smear likely to show lymphopenia, and common cardiac abnormalities that may be associated with could be heterogeophallo, could be truncus, or you can call it as conotruncal anomalies. And some of the counseling sessions you may get, but now because it is online, you cannot expect, but you may have to write the steps, what all things you will tell to the parents. So here it is spinal muscular atrophy. First child is diagnosed clinically as having spinal muscular atrophy and is now quite sick and bedridden. Counsel them regarding recurrence risk and prenatal diagnosis. So the most important aspect here is the first child is clinically diagnosed. So with a clinical diagnosis, you cannot offer a prenatal diagnosis. You should have a molecular diagnosis. So that is the most important point which may mislead you with this question. So you can go through the points. You should be empathetic, explaining the possible diagnosis, inheritance pattern, recurrences, and you have to stress the need for molecular diagnosis in the first child. Then possible to diagnose prenatally only if molecular diagnosis of first child is made. Explain what is chorionic villus sampling or amniocentesis. Explain since she is already 36 years, you have to explain the risk for trisomy. Advise karyotyping also when you are doing the invasive procedure. Also advise after scan. Advise if found to be, because of course some other congenital anomaly should not be missed. Advise if found to be affected, termination is the option, and we can also discuss if it is muscular atrophy, what is the status of treatment as of now. Okay, I think we will stop now. Few more questions are there, but I'll just go through the chat box. Abil, can
Thank you, sir. Sir, shall I stop the meeting?